Hey, Lisa. Okay. So live,
Yes.
ready?
Oh, here, sir.
There. We were not waiting on you. We were just getting ready to get started. It is now 4:32 and we are going to call the meeting of the Monroe County Health Department, May 16th, 2024 meeting to order. Welcome, everybody. I'm glad you could all make it. Laura, hope you can hear us okay.
I can hear you. Can you hear me?
Yes. Okay. So as if we've got all of our technical issues settled here, then I'm going to go ahead and ask for, were there any corrections in the last meeting's minutes?
Read through them and I did not see anything that stood out as a problem. Move to approve minutes.
Second, please.
Second.
Move to second to approve the minutes of the previous meeting. Please, everyone, say aye.
Aye.
Opposed? Motion. Great, thank you. Department updates. Board.
Okay. Lindsay from the Public Health Clinic provided me with just a few updates, so I will give.
What happened?
Active TB cases currently are less than 5 active cases. They have 5 open cases for lead. No communicable diseases to report at this time. Between January and May 16th, they have had 1,261 patient encounters, have provided 812 immunizations, 189 blood pressure screenings, and 42 outreach events, which includes the school clinics. On June 26th and 27th, Public Health Clinic staff will attend the annual Public Health Conference that is being put on by the Indiana Department of Health in Carmel, Indiana. And during outreach events, they have been giving out blood pressure monitors to those who are hypertensive and have no way of monitoring at home. And Amy has asked if we would like to have a board meeting at the Public Health Clinic one time this year, and we could provide an opportunity to tour the building before we meet and allow all of the board members to kind of see some of the, see the clinic and all the different activities they're doing.
Yeah, I think we've
We've
done that,
before,
yeah.
yeah. That's helpful.
It's a good experience. True.
All right. As for general department updates, we did host a hygiene kit building event today. So we had some of the MRC volunteers attended. These kits, some of them will be distributed to Wheeler Mission and then other outreach events that we have through our Public Health Clinic Nursing Division or School Liaison. Interviews for the new position, the Behavioral Health and Wellness Coordinator, will begin the first week of June. Looking at trying to have a July start date for that position. Peter, who is part-time in environmental, and Cameron, who is full-time in foods, have both obtained their ServSafe certification. Peter is currently cross-training in level 1 food inspections.
He's getting all the inspections. Like he's
Okay.
focused on mainly food trucks, but I mean some food trucks are there's level 2 depending on their menu. So, but he's also going to be helping out with farmers market inspections and like risk level 1 inspections throughout the community.
And septic.
How many farmers markets are you supervising now?
So, well, we're inspecting at around 5 markets this summer.
That's weekly. I mean,
They're going on weekly. Yeah.
So he does septic inspections also.
He's being trained in the real estate inspections
real estate.
currently, and then we'll kind of build on to that as well. So he'll be able to work in both of those areas and possibly others in the future, but he's just part-time right now, looking to try to increase some of his hours potentially in 2025.
And so how many people are there doing septic inspections altogether?
Well, 3
Oh.
for sure.
If you count real estate, like Peter's doing real estate inspections right now, but it's just honed in on that right now. But his main focus is just record searches, but as a full-time inspections for real estate, it's 3 right.
And what is the wait time for folks to get an inspection?
I want to say it's about a 2-week turnaround right now. Like we're
Yeah. Okay.
It used to be several years ago, it was over 45 days. We were
Yeah,
out of
okay,
compliance.
got
We were out of compliance. Yeah, we're shooting through these things
Mhm.
compared to what we used
So
to.
what is the guideline for compliance?
I believe we have to respond within 2 weeks.
2 weeks, that's
But doesn't the inspection have to be done within a certain,
30 days.
so 30 days?
Absolutely.
Okay.
Sure.
So, yes, so this will help a lot in both of those areas. Avery, who is our tobacco educator in MRC, is interested in becoming Safe Sleep certified and certified to conduct car seat safety inspections. So looking at developing programming so that she can integrate these services into other health department services and with her Fit to Do clients. Something else we're looking at for 2025 is that hosting biannual community events for some of those services and other health and wellness initiatives that align with our core services. And so this will be helpful to have somebody here in the department that's certified in both of those areas. We have received the STD grant for our GIS. Unfortunately, the amount is only going to cover the cost of one full-time, which is our GIS coordinator during this grant cycle, and an assistant to work approximately 20 hours a week. The grant cycle is started April 1st, 2024 until March 31st. So I am working on moving our other full-time DIS into state funding to secure that position. Linnea is working on cleaning up the website, removing old files, trying to streamline the website. And Linnea and I are working on submitting all of the core service data for the first part of the year. The due date to the state for the first submission is June 15th. And lastly, lots of food code changes and processes. So I'm going to have Mike tell you all about that.
With the new food code coming up, I believe in July, if somebody is working at a retail food establishment and they become ill, for example, like with norovirus, and you're out for a certain amount of time, in order to go back to working at the facility, you need a regulatory authority to approve you to go back. And when they say that, I believe they mean somebody medically approved to clear something to go back to work.
So you need a doctor's note or a nurse
Exactly.
practitioner's note or clinic manager,
Yeah.
like co-clinic or something like that.
Yeah, or like maybe on the public health clinic on Miller Drive, like they
Yeah.
might have to get checked out there before they can go back to work, so they're not contagious anymore. So it won't become foodborne or transmitted person to person.
It's interesting.
So I thought it'd be a good jumping off point to start talking about it now, but when it's,
That's
Big
July.
I believe July, yes. But they're still working on the code. Their lawyers are still. It becomes law.
How would we know if they had know about it?
If they were, for example, if you come to work sick, and you might need a doctor's note to come back or something like that, like if they miss out on work. So some facilities, in order to come back, you have to have a doctor's note.
May I ask a question to Lori?
Oh, yeah. Sorry.
Thank you. Sorry, no, I tried earlier, but my mic was off and then I raised my hand. Okay. About the STD grant. So you're going to be able to keep your other existing position by moving them to the new Health First money, correct?
That is correct.
And are you considering any, and I'm guessing those are both level 1 DIS?
Well, Matthew, and then we have Miranda. Yes.
Right.
Mhm.
So the state calls them level 1 DIS. They can do syphilis and HIV investigations.
Correct.
Okay, so you might want to consider adding, even if it's a part-time level 2 DIS, just to help with the data entry workload and take some of that chlamydia and gonorrhea interviewing off their shoulders with the state money. That was all I wanted to say.
Oh, okay. We can afford one of those in the grant, with the grant that Miranda is in, 20 hours a week. But there are additional funds that we could add on to that in the state fund as well, and preparing for that in 2025 as well.
Okay, all righty.
Full-time or part-time.
Because I think, I mean, you can certainly check with Miranda, but my understanding historically of the workload there is that your district is so big and you have morbidity both in Monroe County and in Vigo County that has to get taken care of, that they can definitely use 2 level 1 positions and a level 2.
Yeah, I mean, ideally, I'd really like to be able to get them another third-time, full-time person too.
Yeah. All right, thank you.
Is this where we discuss, how's it going, talking to the sheriff and getting, syphilis testing in the jail?
Working on getting an appointment.
Uh-huh,
They're not real approachable.
I see. So they just said, or they contacted him and they just
Haven't gotten back to me.
Mhm. Do you think that warrants going to the council meeting to?
Let me work on it just a little bit more. I haven't pushed it much, but I've been kind of tied up doing some other stuff with this insurance stuff. So I'll be working on that the next couple of weeks.
I just think that's super important with because of the neonatal syphilis, and that's
And,
eventually directly impacts that.
right, and it's been done in the past, but it's been a long time. I don't know, 8 or 10 years maybe, do you know, Steve?
I think that's about right.
Since there was testing in the jail.
Yes,
That's it.
it's been at least that long.
I think Steve Sharp was the sheriff the last time it was realized.
Good question though, because that was in our notes as a follow-up thing, and
I'll work on that this
Yeah.
coming week.
anybody else have any questions for Lori on her report? Thank you. Mike? You good? Are you talking?
That was it. Like, any more questions regarding like, employees returning back to work if they do have like septic symptoms or?
I didn't know if you had other things to talk about.
No, that was pretty much about it. But if there's any other questions regarding returning to work, we need a health officer approval before going back.
Okay, any other questions for Mike or Lori? Okay, then we're gonna go ahead and move on to old business. By the way, Aurora, if it comes to something that we're voting on,
Thanks, Mike.
we'll have to see you as well as hear you.
I understand, to make sure that I'm not faking myself. That's fine. I'll turn my camera on when it's time. Thank you.
Okay. All right, just a reminder. Okay, thank you.
Steve, when I was going through the agenda items, under the Futures Family Planning Clinic, I was wondering at that time, since we're talking about the congenital syphilis and so forth, do they test for syphilis in the Futures Clinic?
They can, or DIS is right there, and they can assist as well. So yeah,
I always see the statistics and they always mention chlamydia and gonorrhea and stuff, but they never mention.
There's one of the forms that syphilis has on it.
It's not routinely done in the same way that chlamydia and gonorrhea is because of the morbidity in the general population.
It's also a different type of test.
But if they're drawing blood for other things neonatally, or prenatally, why aren't we routinely getting a VDRL?
Well, they're not, and it's not a VDRL anymore.
It's an
So the family planning people aren't going to be doing prenatal care. They're not going to be drawing blood for anything related to that. The DIS only draw blood for syphilis testing only among people at increased behavioral risk. So the blanket kind of syphilis testing screening that some of you may be familiar with from back several decades ago has been long gone. Long gone. Syphilis testing is only performed on specific populations. And you're right, with pregnant women, it should be done at their first prenatal visit. But family planning doesn't do prenatal care.
And just for a little background, this was probably 6-7 years ago. It came to the forefront that pregnant women were being cared for other than by board certified OBGYN physicians. And they made it a policy that if a pregnant woman shows up in the emergency room or postpartum, that an OB doctor will see them, not just the emergency room physician or nurse practitioner.
So the patients come to the clinic, they fill out a form that decides if they get, or if they should be tested with a blood test for RPR. Is that how that works?
That could be a screening tool
Mhm.
among certain populations,
So what's,
but it won't be pregnant people.
right, but what happens at our clinic, at the Futures Clinic? The patient comes, the ex-patient comes in, and then does every patient receive a questionnaire that?
Yeah, in fact, among the questionnaires that are filled, it's a very lengthy historical questionnaire, and it includes a sexual health section. And it includes questions like, do you have sex with same-sex partners? Does your partner have sex with other people?
Mhm.
And so there's flags that are raised with those questions, and those people are so screened selectively.
And how many women actually know not only whether their partner is having sex with other women, and with how many women and how safely?
That's a age-old question.
Yeah,
But it's
With no good answer. So
we're limited.
probably the answer is they don't have a
Yeah.
clue, but we also follow the screening recommendations set out by the U.S. Preventive Services Task Force as well as CDC for chlamydia, gonorrhea, and syphilis and HIV. So there's a whole evidence-based body of information if you want to look it up. So family planning, because they see primarily females of childbearing age, the screening recommendation is any sexually active female between the age of 15 and 26 is screened for chlamydia and gonorrhea annually. That's the screening recommendation for that. Syphilis, as Dr. Britton and I have said, follows a different, it's behavioral risk, and it's based on the patient's stated behavioral risk, which doesn't mean that their partners don't also put them at risk. Absolutely.
There's other behavioral questions that are asked, like, have you had a new sex partner in the last 6 months, and that sort of thing.
so the known syphilis babies in this state, much less across the country, are we saying that their mothers did not fit the screening criteria, or that they weren't screened? To what exactly do we think is the reason for the rise in syphilis and in congenital syphilis?
Are you referencing a rise in Indiana congenital syphilis from some report you have in front of you that I am not seeing?
Not in front of me at the moment.
We got
But
it
we've
this
got-
week. Yeah,
Oh,
something
I
came
got it
over my,
before.
it was through the state. And
Yeah.
it said the incidence was
It's
like
rising.
200% greater than.
Yes, certainly when the the director of the Department of Health was here, she mentioned it. And it is nationwide. So I'm asking.
Okay, so
Meeting the criteria, or are we simply not screening them?
I wanted to know how to respond to your question, which is why I asked for clarification. So the rise in congenital syphilis nationwide that has been going on for several years is due to a variety of factors. Indiana is a little different. For one thing that happened several years ago is the CDC changed the surveillance case definition for congenital syphilis to make it more sensitive on purpose. That resulted in more babies being categorized as congenital syphilis cases than they had been before. So part of it is an artifact of the change in the surveillance case definition. In Indiana, and I can send you guys my paper if you like, but I actually examined just that question several years ago. So I actually do know the answer. I'm not sure we want to take time in this meeting to talk about it, but it's not nationwide. Yes, there are some people that are not screened according to CDC screening recommendations for pregnant women. There are many pregnant women who do not enter prenatal care, so they can't possibly be screened because they're not interacting with a healthcare provider. They show up at delivery, for example. They show up at delivery never having had prenatal care, so no interaction. And then in some regions of the country, although this was not a problem in Indiana, I'm happy to say, physicians, even when they saw a pregnant woman, were not meeting the screening guidelines, or if they screened and she was positive, they were not treating her 30 days before delivery to prevent that congenital case. Indiana, at the time of my examination, did not have issues with providers at all. Providers were doing what CDC recommendations stated.
Thank you.
You are very welcome. I'll send everybody the paper.
Thanks.
She's a font of information.
Yeah, no kidding. This is
So
great.
in being practical, so we can't just sort of offer every patient that comes through the door. They have to meet these criteria for the blood work to be ordered. Is that correct? To meet criteria to get it paid for?
That is correct. Family planning doesn't have a family Title 10 in this country. There's no budget for STD testing. So they partner with STD programs for that, and STD programs and Title 10 clinics follow the screening guidelines set out by the federal agencies, CDC, ACOG, USPSTF.
Patients can request the test.
Of course, yes, absolutely.
Okay, further discussion on this topic, which is fascinating, really. Okay. Thanks for all your input. Lori, I assume you have the commissioner's report.
Yes, it's just that report.
Just this,
Yep, so that's just the monthly right there that you have it in there.
we need to discuss.
I would, yes, so just review, approve, acknowledge that you received it and we're
What
in
is it again?
compliance with the code. Can I see a copy of it?
Yeah. Sure.
This copy here. So the monthly.
Oh, okay.
Mhm.
Yes, sure.
Thank you.
Move acknowledgement.
So code says to provide a copy of this to the board officially approves it, and then we store it for record keeping.
So we need to officially. approve.
So, yeah, I moved acknowledgement.
Then I'll second.
Okay, it's been moved and seconded.
I'll second.
Been moved and seconded to acknowledge the commissioner's report.
The health department.
The health department report to the commissioners. Well, I guess it would be a commissioner's report with apostrophe.
I'm gonna just, if I can make a comment here, I was in the department the other day and Cody showed me his screening that he's doing for tick
Oh.
identification.
Oh.
Pretty darn cool.
Yeah.
He's got this elaborate, GIS overlay of where he's finding ticks. And he showed me the apparatus that he's using to collect them and how they're being collected and identified. And
That's new stuff.
it's brand new. Yeah, and it seems like he's doing a really good job with it.
It's been moved and seconded to approve the. No, approve. All those in favor, please say aye. Opposed?
I'm saying aye, but I was muted again and I took off my camera, but there's no, so do you need my face? Do you need my face for the vote?
If you want your vote to count, yes.
Well, I think someone else is controlling the camera. Let me try again. Okay, there we go. Can you see me?
Yes,
Aye.
although
Thank-
it shows that it shows maybe this.
What's it
Anyway,
showing?
We see you.
we see you. Yep,
Okay,
we're
okay.
good. We
All
got
right.
it. Duly noted. Okay, we're going to discuss the information requested regarding the school. Well, first, are they still questioning?
So I did receive some feedback. They were not aware of the KPI data points, all of the information that we are required to submit to the state in exchange for the HFI dollars. So I think once they were aware of that, they acknowledged that a lot of those areas they are not routinely doing. They could fit the criteria for the blood pressure screenings in some instances. So
When you say not routinely doing it, are you talking about it's not part of the criteria? Is that what you said?
right, it's
They're
not.
not checking blood pressure. I mean, at the top, it tells you they're not checking blood pressures. There are so many things they're not doing.
Mhm.
As opposed to the requirements at the bottom. And the thing that was most interesting to me about this was the number of office visits and the number of students, which makes it about 9.5 visits per student who actually
exactly.
sees the nurse. And I'm wondering what their criteria are for then suggesting that that child be seen by the social worker in the schools. Obviously, there's something going on if a single child is coming in at least 9 times in a school year. It's concerning, to say the least. And yes, it may be the girl who comes in every month and says she's got cramps, so she doesn't have to go to PE, but there may be other things going on. And when I'm looking at the fact that they're not routinely, when kids come in and are feeling kind of funny, they aren't routinely checking blood glucose unless they have criteria for doing that. There are things that they're not thinking about. And, I don't know what they're doing. And I'd be really curious to know, are they just doing kind of a knee-jerk thing with any child who comes in? Does the nurse have that kind of clinical acumen that she can figure out what's going on in the home, in the family, with this child, in the classroom, all those other things, much less with their general health?
Many times it's not the nurse, it's an health aide.
That's doing these.
There's
Right, there's one
nurses for
nurse
many
and-
schools.
So these are just health aides who really can't, unless we give them genuine protocols that they have to fulfill. Then kids are gonna just fall through. Anyway, that was interesting to read when I read how little was being done with these kids.
Do you do any kind of mental health assessment? I see nothing. I see nothing in that, which is a little bit troubling. All right, do we have any other further discussion on those proposals? I mean, do we need action on this or something? Just, it's just informational?
I think they're looking for a response about funding their proposals. Are we interested in funding their proposals, not funding their proposals?
No,
or-
I say no, because they had two proposals, right? One was the equipment they were gonna bring, and then SIP
Oh,
was gonna
Mhm.
charge for that and get paid for it. So I say on that one, no. And the other one, what was the other one? That
The
they were,
EMR system.
oh, the EMR, and no, that's my opinion. So my vote is no, we're not interested.
Yeah, the EMR system came with a hefty
Yeah,
yearly
it's like a,
Yearly fee,
maintenance.
that's not our role.
No,
Mhm.
All right, so,
Oh, yes,
do we need,
oh, yes,
that was, yeah, that was just this for the school funding. So if everyone's in agreement, no to, not accept the proposals, then I can provide that feedback.
yeah, why don't we?
So,
Somebody
I
make
move to reject the proposal for funding.
proposals.
This is-
Second.
Proposals.
Second. It's been moved to reject the proposals made by the school systems for the EMR and the video. It's not video conferencing, it's video
Sullivan?
Tell-
telehealth. All those in favor, please say aye.
I-
Opposed? Thank you. Gift card policy.
Yes. So Miranda has drafted this gift card policy for this. So this applies strictly to grants that will allow the purchase and distribution of gift cards because the county does not allow that with our county dollars. So this is basically just an outline of the procedure. Miranda would take the responsibility of tracking all of these. Essentially, the same format could be adopted to other grants if other grants allow gift card, but it would just be tailored to that specific grant in that department. We are just required by the auditor's office to have an internal policy and procedure on file for how we're going to manage and keep track of these gift cards.
Just curious, do other departments health departments do this?
I think some, yeah. So I think it's pretty typical with the DIS and who have those grants to offer these. Some
Incentives to test. Mhm.
Okay, so if this is gonna be our official policy, I think we need an official approval of this policy. So,
Can I just ask a question? How will it be determined where in the $5 to $20 range, someone gets a grant, and are there a certain number per year
or a
for a
dollar
particular, well, for a particular individual? That's the only part that I'm not really
Mhm.
getting at. If somebody comes back month after month for another testing, do they keep getting gift cards?
That's a great question, actually, and I mean, I'm happy to maybe clarify that because maybe we need to put a stipulation in there that it's only one per year or only this dollar amount within the grant, and that way we can, make sure that it's fair across the board.
And it's not that I don't want everyone to be tested as much as they really need to be, but I just think that it would be helpful for us to, one, be able to track who's getting them. I assume that we are going to track who's
Yes.
getting it
Mhm.
and the amount,
Yes.
so that we can see if we've got people showing up quite regularly.
Mhm.
Frequent flyers.
Mhm.
And I mean, it's an incentive.
they
And I
wouldn't
think
do
that's
anything without getting once they get started.
well, yeah, the carrot and stick and all that.
And I mean, just the fact that they'll be tested is great, but I can see where lots of individuals don't see that as a big deal because then what? But I would be curious about those.
Well,
I don't know what else anybody else is interested in.
I think that makes a lot of sense, something that's standardized.
So you want to table this?
Well, I'll talk to Miranda and see if we can put in some more specifics. Criteria.
Okay, is it necessary for legal to look it over too? or-
Yeah, I'm gonna send it over to them.
Okay,
Mhm.
all right, so we'll table this, it's okay, until our next meeting with, to make some refinements and let legal have a chance to look at it. Right. Moving to new business. Approval of the partnership proposal with the city of Bloomington Parks and Rec.
Yes. So using the information from our 2023 annual report and trying to take that information and looking at our core service requirements and needs. I did inquire about some type of swim program that we could offer and partner with an organization on. Drowning deaths are in 2023 were the third leading cause of injury resulting in accidental death in Monroe County. So this is one proposed program that would be offered over the summer. It is a 2-week program. Essentially within that time period, it allows different ranges so that they have different groups and essentially families can pick a date range that fits best into their schedule. So could potentially expand a service such as this in the future, but this kind of gives us maybe a good starting point to see if this kind of partnership works well.
Yeah, was there?
I was surprised that Parks and Rec wouldn't already have this program.
I think that they have before in the past, and I think to some extent, but I maybe something happened with the funding with that.
This would be great.
It's just $3,520.
I didn't recall it.
For 70 children.
Yeah, and I would love for Tim Street or whoever else to come back to us and let us know kind of how those 70 children managed at the end of the 2 weeks and how many of them were able to float, were able to maybe swim across, but could at least get themselves out of some sort of danger.
Yeah, I think that's a great idea. I think we could also consider writing into these service contracts some type of a reporting above and beyond just the data, that they need to maybe submit pictures or submit just a short paragraph summary of kind of the program itself or present in person.
So do we,
Maybe they could, so can we request that they write in? I think there are a few maneuvers in the swim that the child learns to save themselves if they are in a body of water for a long period of time. And that they could say, you know, the statistics are this number of kids of the 70 completed the task and were able to be in a situation for 3 minutes or whatever it is to be able to save themselves. I think that would be a great statistic to be able to present or for us to see. Yeah, sure.
It's great because they do tell us what the fundamental aquatic skills are that they are required. And but it would be nice to know absolutely how many of the children, if indeed they get 70 children, how many of them are able to actually meet these criteria and get this skill level, much less if they exceed that skill level. That would be lovely to know too.
Sure. I'll talk with Shelby and, see, kind of what we can come up with and outline specifics around that.
Otherwise, I move to approve expenditure of our Health First Indiana funding for this Bloomington Parks and Rec swim adventure.
Second.
Any further discussion?
Laura, turn on your light.
Oh. Here I come. It takes a minute. I didn't interrupt, but I'm so excited about that. I feel like it's a very small investment for a huge return if we can prevent drowning deaths. I think we should just do that all the time.
And I think we could even do programming through Indiana University as well. I think there's a couple in this area.
Yeah, so anyway, let's vote. Aye.
All those in favor, please say aye.
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 Opposed? No, I think it's an excellent use of money. It's a bargain.
Mhm.
Okay, our next agenda item has monopolized a lot of time, hasn't it?
Oh, my
Dr.
God.
Britton?
It's just been really, there's been a lot of back and forth, and I've been given conflicting information.
Yes, yeah, well,
And I'm pretty close to a solution.
yeah, well, I felt muddled completely until even, and we had a meeting on, Lori and I had a meeting on Monday with Molly, the county attorneys. And I thought I had a little better understanding, but then you got some information from your insurance company, and then I was completely confused again. So here's the latest email to me from one of our county attorneys. This is today. Dr. Pritchard, hopefully this information will clarify any of the confusion that may have resulted from a series of emails yesterday. I have confirmed again today that the county's policy limits what Dr. Britton is covered for, what capacity he is covered for, since they are only covering and charging premium for him as a health officer. Dr. Britton is covered only with respects for administering or vaccines/drugs and prescribing standing orders with respects to his collaborating duties applies to both your role as the medical director at the Futures Clinic, where he is collaborating physician, and his role as health officer. However, there are situations that Dr. Britton could have to take actions as a health officer that falls outside the scope of these limitations. For example, diagnoses and developing a treatment plan in the context of disease intervention could not be covered. I will be sending Dr. Britton an email clarifying the coverage as well. Pursuant to Dr. Britton's contract, he is to maintain in full force and effect insurance coverage for the performance of professional services as the local health officer. At the beginning of April, Dr. Britton advised that his private practice insurer does not cover him in the capacity as health officer. The county has recommended that Dr. Britton needs to obtain his own independent coverage to rectify this issue. Dr. Britton's own malpractice insurer, who insures him for his private practice, has also recommended that he needs additional coverage. Therefore, it is my recommendation that the health board requests that Dr. Britton furnish a certificate of insurance to the health board within 30 days, or his contract should be terminated. Procedurally, if the health board approves an amendment to Dr. Britton's contract, it would be provided to the commissioners for approval. If an amendment is approved that increase in the cost of the contract, the health department may need an additional appropriation if there is not sufficient funds to do in-house transfers. The council office can assist with identifying funding sources, or if an additional appropriation is needed at this time, if the health board would like that to do so, meaning council office. So basically, what we've determined is that Dr. Britton's and probably Dr. Sharp's insurance, private insurance, was not adequately covering his duties as health officer. So this is probably a long-standing problem.
I'm gonna throw a wrench in this.
Okay,
I've had further communication with the underwriter of the policy that the county carries for this
okay.
position.
Island?
It's actually Evanston,
Oh, Evanston, right,
Insurance.
right, that's right.
and Susan Wood is a local agent. And the original policy says the insured is covered. And in the enclosures that you guys have seen recently, it says that duties as health officer and collaboration for me, and in the name of the insured, they hid the name of the insured on page 19. And I sent you a copy of that. And the insured is Monroe County Health Department, Futures Family Planning Clinic. In that summary, I'm the added physician and Dr. Sharp is the departing physician. So he has been covered in the past, according to that document, and I have been covered since.
To a certain extent.
Yeah,
It's
to the certain extent that you're not providing direct care.
well,
But-
it covers health officer and collaboration.
I'm just gonna buy what Molly said.
I know,
That's
but
legal here,
but-
so.
that doesn't include the communication I've had in the last day with the Evanston.
I think it was your own insurance company that suggested that.
Well,
you need
they
this additional
said
policy,
that
right?
they couldn't
The rider.
determine, no, they said that they could not determine from the information they had whether or not I was covered. They didn't have access to that full policy. And I'm trying to get that to them to review.
Okay, so here's the dilemma. Is that we are uncertain if the coverage is adequate or not. So we are right now going down the path of it's not adequate.
I'm totally fine with that, but there has been a suggestion that it was adequate.
So the cost of the rider, if it's not, is the roughly $3,800.
Right.
Now, Dr. Britton did not know at the time that he negotiated his original contract that there would be an additional fee for his malpractice insurance, because prior to this, there was not.
Correct.
Is this accurate so far? So I am suggesting that we support renegotiation of his contract in order to include the cost of the increase in insurance. Allow him that opportunity. And I would suggest, and Aurora, if you want to jump in anywhere here, because she's also been involved, that we submit a motion to support the acquisition of this rider and include the cost. Ask the commissioners to consider an alteration in his contract that would include the cost of this. That's not the final issue. The final issue is if they support it, then it has to go to council, I think, for review, because it's a fiscal matter, unless we have money inside the department that we're moving around, but that hasn't been something that we've done in the past. Yes.
So will this cover both the health officer as well as Futures Clinic?
Okay, here, that's a good question, and I don't think that we know that that is actually true yet.
Yeah,
know that-
we need clarification on that for sure.
We know that that would cover his duties as health officer. But there is a clause in Dr. Britton's contract that says that he, in the absence of the nurse practitioner or in a special situation, he may be asked to see a patient, or the patient may ask to see a physician, and in the absence of some referring physician who could see them I guess in an expedient manner, Dr. Britton would then see that patient, which of course would be direct patient care.
But maybe I'm completely off base, but I'm wondering, isn't then Dr. Britton also basically the overseeing medical officer for Futures Clinic, and therefore the physician that oversees our nurse practitioner legally? So
It's the same in dentistry, it's direct, it's sort of supervised or
Yes,
prescription supervision,
yes, exactly.
which then requires the proper, the proper
Well,
malpractice.
they specifically do state in the writer, if you will, the 2 or 3 page writer that you guys have seen, that it covers collaboration.
Just not direct patient care. So, yeah.
Yeah, it covers the collaborating duties, but see, this is where I was always, in Aurora, you had some really good definitions of direct patient care the other day when I know what direct patient care is, but I also know that if Dr. Britton is supervising nurse practitioners, then isn't he by default also liable for
No.
some of the.
No, I have never in 30 years of doing this for a Title X agency and for all the STD clinics I've worked at, I have never heard that argument advanced. It's a logical argument, but advanced practice nurses are able to practice somewhat independently. They make their own judgments. The physician under whom they practice with a collaborative practice agreement, that physician, it's the reason why Dr. Britton does periodic chart reviews. So if he goes in those charts, he reads them, he makes sure the nurse practitioners are doing everything according to correct medical standards, and that's the extent of the oversight. So direct patient care would have to be Dr. Britton himself walks into an exam room in our Title X clinic, conducts an examination of a patient, possibly collects specimens, possibly prescribes medication, which I don't see him ever having a need to do. So, because the nurse practitioners do that.
I thought you prescribed 5% according to the agreement. Emma had said you're required to prescribe 5% and then just oversee the rest of what she prescribed.
Yeah. I've been getting recently prescriptions to sign, but that's more recent, and that hasn't been historic. Now, I have historically, gone in and inserted an IUD or, exam, that kind of thing.
Well, that's definitely direct patient care.
Oh, yeah. But that hasn't happened in the last couple of years, in part because of the people that have been staffing the clinic have had the skills set to where I didn't need to do that. And so the whole idea of direct patient care hasn't really come to the surface until recently, because it hasn't come up.
But don't we have to be prepared in the?
Of course.
Of
course.
The situation where.
Yeah.
Mandatory or something, that's we have to have a contingent,
Right, so what I would propose is, I'd like to send this full insurance document to my carrier to make sure that the coverage that they're offering me for the $3,800 is sufficient to allow for direct patient care, or if it's even needed based on what their interpretation of that document is.
Or are we gonna need a policy for both?
But do we need an additional policy?
Yeah.
So I just got this information in the last 24 hours.
Yeah, I know.
And I've been looking for it for a long time. Anyway, I'm gonna have my personal private practice insurance company that's underwriting this
Yeah.
$3,800 policy.
I wish
Look at
that they had access to all this information prior to this to make a determination as to whether, because this would have solved this a long time ago.
I know.
If they had had this information and they could determine if you're adequately covered and said no or yes, but no, you need this policy, and here's how much it's going to cost. And then it makes it really simple.
It could be a lot simpler than it is. But I had to get special permission just to get a copy of the contract.
Okay,
That's what the agent told me. I'm not sure I can send it to you. I gotta
okay,
get
so
permission.
basically what they're suggesting is that we have 30 days to get this done, which seems reasonable considering it's
Yeah.
gone on for a while.
Yeah. So
But what I would like today is if we are going to have to, if Dr. Britton is going to have to acquire additional policy or maybe two, that we support a renegotiation of his contract to cover those expenses only, nothing else, just those expenses.
I would so move.
Thank
I
you.
will second.
Yeah.
So we have a
Been moved and
motion.
seconded. Lisa, you have any?
Well, for me, it's complicated, I think, because there's, and I was gonna bring this up at the end in terms of the Futures Clinic and its funding, and then I think that directly impacts that decision. I don't, so I'm saying, I guess I would say until we make decisions about Futures Clinic and, you know, the future of that in terms of its sustainability, I would say, I don't see us, I guess, going to the county again and saying, you know, we need this money for this. So I would, I can either say no or abstain until we,
Well, maybe this will put a little, the county requires and is liable now. So this is not a question of this. I
it's
mean,
not optional.
this is not optional. Now. This is, it's, what we're asking basically, do we support Dr. Britton's ability to renegotiate his contract to include the cost of the insurance, should he need it? And I think that that's only fair because he didn't expect to have this expense. And in future recruiting of physicians for that position, they're going to have to, they will know that there's cost
cost associated.
associated with it and can negotiate their contract.
And if the Futures Clinic doesn't go forward, it's moot.
It's a moot.
Yeah.
So,
And just for whatever it's worth, if you purchase a malpractice policy and you terminate your care before the end of that time frame, you get a refund.
sure.
Prorated.
Mhm.
It's a prorated refund.
So maybe under those circumstances,
So my vote will be aye.
Thank
Okay.
so all in favor, please say aye.
Aye. Oh, let me turn on my camera. Aye.
There we go.
There we go.
All right, and Dr. Britton, please get that information to your,
I'm sending it right now.
okay.
I wanted to have this
Yeah, thank you.
discussion first.
Right, and thank you for supporting that. I think it's only fair.
Yeah, thank you, everybody. It's like, you know, it really isn't an option. You have to have, you know that. You gotta have
Yes, for sure.
malpractice coverage. It's a pain in the backside. but,
Okay, got that, so we can move on to our budget. That's you, Laura.
Thanks, Vicky.
So, I think what I'll do, if it's okay, is provide just a little overview, maybe point out some of the increases or decreases or changes, some of kind of my thoughts, and then, whatever questions, I guess, or concerns come up. So starting with, 1159, so this is our, local county fund. So a few changes to this, primarily, moving some of our employees who were in this fund over into 1161. So did not move all of those the first year of 2024 because our Health First Indiana dollar amount was lower. Now that we have a little bit of a higher amount and the county match side actually decreases, this provides an opportunity to kind of balance that out. Some of the supply costs and services have roughly stayed the same. I have added in a little bit for fuel and for supplies to help cover our DIS. They have a lot of mileage costs and supply costs that our grants are just cannot sustain the full extent of those at this time. Added in some additional funds for clothing apparel for our field staff. So health department logo apparel, supplies, slip resistant, steel toe shoes, to provide some assistance with that. And our public health contract was moved last year and it's remaining in 1161. So any questions on that? I'm happy. This does amount to just a little over $800,000. I will say that the county minimum opt-in amount as of right now is $681,000. Should the county say that they only want to put in that minimum amount, we will have to pull funds from one of these other accounts to make up that difference. So just something to keep in mind with that.
Laura, did I understand that you were increasing the clothing a little bit? It looks to me like it's decreasing.
It has, so increasing the stipend amount. So previously, we only provided the stipend for environmental employees who were assisting in wastewater. Now that we're moving forward with the cross training and trying to help provide some of that coverage now for all of the environmental employees. Let's see. Moving on to 1161. So this will be our Health First Indiana. Projected anticipated amount, at least this first budget submission, will be just a little over $3 million, which sounds like a whole lot of money, but once you actually add everything in there, it's not so much. So the green items, I guess I should clarify, that was just an indicator for me. I was trying to, we have standard county increases when employees hit certain years of service. So that's just to help me kind of keep track of that and gauge when those salary increases will go up for certain employees. One question I guess I do have is, should I rework all of the department employee salaries to put those at a 40-hour work week to ensure that we have money budgeted for that? I have been getting requests from some employees that really needing that 40 hours. I don't necessarily think that it's necessary across the board, but it could be something that we considered. These are non-reverting funds, so if for employees who don't get moved to 40 hours, we could transfer those funds elsewhere if and when needed. So
Do you have any idea how many of your employees are still at 35 hours?
Well, just about all of them. I think there's just three of us, and then if they approve Miranda, that will be 4 of us at 40 hours.
Okay.
Everyone else is 35.
Isn't the council fairly supportive?
They think 40 hours makes
40,
sense.
yeah.
I think 40 hours makes a lot of sense, but if we're not gonna require everybody to work 40 hours because you're concerned people will quit because they really don't want to do that. I think your suggestion to just have it in the budget just in case is probably wise.
Okay, perfect. So I almost changed that today, but I figured I would wait before I did that trouble. But so I think that it makes sense. That way we at least know we have money secured if and when, or for those employees that actually do need it. So if there's support with that, I'll make that adjustment.
Sure.
So let's see, going over some of the others, for the employee training and development, I did increase those amounts in 2025 for all employees. I think it was really great to try this out for 2024. Previously, I really had no idea how much certifications or how much standard training was costing for any employee. It was just in one big bucket, and kind of when the money ran out, the money ran out. So we've quickly kind of found out and have a good idea about what some of this costs. So that amount has increased to be able to provide additional amounts for all employees.
Does First Health Indiana require additional training for certain people?
Yes. So yes, for certain requirements and certifications. Let's see. So medical supplies, the reason for the big jump in that. So when I complete the state budget, this will be broken down. It's really itemized. When I do it for the county budget, everything's kind of lumped into big buckets. But essentially a lot of that will be going towards supplies for health fairs and our outreach events, such as the hygiene kits, blood pressure monitoring kits, and so forth. Radon kits, so we're going to continue doing that. We've had some additional supply requests from the public health clinic for our lead testing services. Also added in some money to be able to provide the safe sleep and car seat. And let's see. The IU Health Nursing contract. So we did lose one of the COVID grants that was helping to support those. So that small increase to account for that grant going away, as well as adding in an additional full-time LPN to that contract for them in 2025. I do think it makes sense to be able to add another LPN for them. For example, Hendricks County has 7 nurses. They've really just been operating with 3. So I think it's needed.
You indicated earlier that the requirement for First Health Indiana that there be 24-hour availability might require additional nursing hours from IU.
Yes, and so I think that would help offset this. I'm also talking to Lindsay about how we can expand the hours to offer Friday hours. Currently, they're only offering hours Monday through Thursday and 1 Saturday a month. When they do school clinics, or for example, like the TB testing, that really limits the appointment availability. So I'd really like to see if we could expand that. And I think being able to offer Fridays, and even if it's just a half day, is a good first start. Everything kind of happens on Fridays anyways. So.
Do we offer more Saturdays right before school so that parents who are working Monday through Friday have a better chance of getting their kids in before school starts?
We could, and I'll certainly talk to Lindsay about that. I do think that they have really good turnout when they do the clinics in the schools. But I will clarify about that and whether we need to look at opening that up.
Thanks.
I still need to get with HealthNet to work on.
Just looking at that.
Yeah, so potentially even I did meet them, and we could possibly expand that and add on more partnerships. We just haven't had a chance to meet just yet. What I will say about
Do we want
the,
to ask, Health Net to send us, and I think we did this maybe last year, we were talking about budget, have them send us a blurb that tells what they're doing with the money. I mean, that's always totally reasonable.
yes.
I think we should do that every year, yes.
Yes, so I will reach out about that and trying to work on scheduling a meeting to talk about 2025. As for the contractual line, so that dollar amount that is there, if this were my opinion and what I feel most comfortable with, I would be submitting that to the state, essentially saying this is a pot of money that we are not quite sure what we're going to kind of tie it to at this time, but we know it will address core services. I think that'll allow us flexibility to take the next few months. All the way at the bottom, 30006,
Mhm.
second from the bottom.
Yeah, it's a big number.
Mhm.
So, you mentioned here that putting everybody at 40 hours would add about 200,000 to the payroll. Is that,
Oh, I don't think it would be,
what
well,
does that number mean? What, that 200, I don't understand that number
where, let me see.
next to, 3006.
Oh, okay, so that 200,000 is essentially accounting for a rough estimate. If the county only wants to do their minimum opt-in route amount, we would need to pull money from 1161
Oh, I see.
to make up the difference of what we're losing from 1159.
Okay.
So, I mean, I've kind of tried to pocket in some buffers because things come up, and we don't really know. So that could automatically decrease that amount. We do have the new proposals from IU Health, that I set in a separate attachment, which we can talk about. That would take another $400,000. And then you start thinking and talking about these other service agreements, even the small ones that we currently have and that we could expand on, like the swim programming, the Limelight recovery for the substance abuse. So those all kind of add up, and quickly that
Sure.
is not really there.
And what is 400,000 covered for IU Health? Where, or when did you send us that contract?
It was this Excel sheet. These are proposals, a couple different ones.
Oh, okay.
It was just, yeah, I just got it the other day.
That's when you sent us the additional budget.
Yeah, so it was, yeah, just this week. So for example, the first one proposed, the doula, I think it's a good concept. I wonder if IU Health would perhaps match us. Perhaps we fund one position, they
Right.
fund one position, and then we
Right.
partner.
Right.
The LPN I have already added into their standard contract because I think it makes sense. I think they could use another nurse. There is a second LPN in there. I'm not sure. I don't feel like we could really afford that.
Mhm.
Or that we could go down that road right now. Let's see, there was a project manager one for case manage. So there were several paramedicine programs. I have been talking to Bloomington, the city of Bloomington, their mobile integrated care about paramedicine programming. I'd like to be able to have some time to talk more with them about those services. I don't think it would be smart to commit to all these because it's over $400,000.
I'm also confused by, that we have two peer recovery doulas, which is lovely, but then we also have peer recovery support. And it's like, well, most doulas I know are both pre and post. So I'm confused as to why they're separating out additional peer recovery support.
Yes, so Mhm. These are all the things I think that we have not even had a chance to kind of discuss or kind of get into. Mhm.
I think our grassroots things that we do, like even this one thing, or this affects a lot more people and at a less of a cost. I mean, you have X amount of money and to
Mhm.
spend.
Mhm.
I mean, we don't have to vote on these things right now, just.
Mhm. Yeah, so that's why I think if I just submit this to the state,
Mhm.
saying whatever, when I make these adjustments,
Mhm.
whatever that amount is, these will be for core
Mhm.
services, we don't know yet. I've
Right.
been doing that this year.
Yeah.
When something comes up, I submit a budget revision. Hey, we're gonna contract with Limelight. I need to move this $5,000 here. So it's a pretty easy process. I've
Okay.
gotten used to it.
Awesome.
When is this ultimately due?
Well, June 1st
Okay.
is the first, and then we'll find out the final numbers in the fall and then submit that through the
Mhm.
county. But then otherwise, the state, you can submit like budget.
So this isn't hard and fast.
No, I mean, I have to submit a
Mhm.
first submission, but we
Right.
still, in my opinion, we should take some time to, you know,
Should we remind the council how much money they're saving by
by
withdrawing
opting in.
funds from us and opting in? When we're trying to get our 800,000 initially, them not withholding.
And the initial input projection was 1.5 million, right?
This year, you mean,
Yes.
for Health First?
Mhm.
Mhm.
I mean, seriously, I mean, I think they need to be reminded of how much money they're,
Unfortunately, some counties are getting less money for
Mhm.
opting in,
Mhm.
but have all these additional requirements. Yeah.
I think a lot of other counties weren't as well prepared.
Monroe County was in a really great place.
I think so.
Um,
So this is like a first draft.
mhm, yes.
So we need to, I would assume, Your Honor, we would need to move approval of this draft
Mhm.
to the state. Is that what we're looking for here?
Yes, you would do that. No, we know that there's gonna be some changes, but to have a vote and approval. Mhm.
we vote on the final
In the fall.
in the fall, it's usually like in July, August. Well, traditionally it was in July and August. It's probably it'll be later than that.
Mhm.
Right.
But do you need approval to move forward?
Yes, definitely
let's
for
just
the
do that.
1161.
Okay.
Lori, I have a question on
Mhm.
this 3006 contractual. Does
Mhm.
that have to do with oh no, that's a different, so that's under the 1159, the health fund. So what is the 20,000 IRA? How's that? Is that
Mhm.
what's added to the 2025 proposed budget?
For an 1159, yes. So the IRA is, they, are the syringe service program. We have been providing
Oh, okay.
$20,000 for that contract. So it's just adding that into the health officer and medical director. The per Indiana statute, the health officer, has to be paid out of 1159.
Mhm.
Mhm.
Okay.
So I'm going to move approval of this draft to go forward.
A second?
Further discussion? All those in favor, please say aye.
Aye.
Surprise.
Well, you're actually loud when you come over to the speakers here.
Oh, I'm sorry. I'll be quieter.
Oh, that's so much. It's fine. All right, great.
Oh, can I add one thing?
Of course.
Dr. Reiterban had inquired about the mitigation systems. So I did find out about that, essential.
Radon.
So cost of that is around $1,000 to $1,200 each.
Mhm.
for those services.
Thanks. And where does that funding come from when we assist people?
Well,
Is that
currently
kind
nowhere, I don't think.
Oh, okay.
At least not here. It's a program that we could develop internally, and I think that's something else we could do with a portion of that money if we wanted to. We would just need to figure out what criteria to and who's eligible.
Yeah, I
Mhm,
think those are the
mhm,
biggies and, because if we're testing for radon and if we have people in this community who cannot afford mitigation, then we're already, it's kind of like going into the prison and saying, we're testing for HIV, but we can't treat you.
mhm.
Yeah.
So, yeah, I would like to see what we can work out to find a way of assisting people.
Mhm,
And yeah, it will be what level of poverty
mhm,
would we need?
mhm.
I think the other thing and I don't know if we're tracking how often after radon testing, I'm sure we are, we're actually seeing mitigation systems being put into place and meeting criteria for lowering to healthy levels.
Mhm,
But certainly, if any impoverished person happens to own their own home in this county
mhm,
and happens to get radon testing and we prove that they are at bad levels and cannot afford because they're still living in grandma's house that was paid for years ago and it's falling down around them, how are we going to help them protect their health?
mhm.
Does Mike keep records of who has an over the critical value
Mhm.
reading?
Yeah,
We've
keep
got
all that.
reports before
Yeah.
that says how many have mitigation.
Sure, but I'd like to know kind of the people who can't afford the mitigation.
Mhm.
Any other board comments? People have
I
any?
have something which isn't really by way of a comment, but it's for your information.
Yeah.
It's something that came out of the Clinical and Translational Sciences Institute conference
Oh, cool.
here.
What do you got? Mhm.
And that is how scary the climate change issues are that might be presented to the county in the way of everything ranging from increasing the number of vectors that transmit diseases that we haven't seen from a long time ago that are moving north suddenly and are appearing in the United States for the first time. Dengue, babesiosis, weird things like the Lone Star tick that's making people allergic to meat.
Dairy.
The extended growth period for wasps and hornets that are resulting in more stinging deaths. It's a weird collection of things.
Sure.
And on those grounds, Diane Henschel and I, who attended this conference and heard about some of these things, sort of got our heads together and made this proposal, which we're submitting to the commissioners.
There was a piece, I think, in the Times, that 2023 was the warmest summer in the Northern Hemisphere in 2,000 years.
And heat kills.
Yeah, it's vicious. Cody was telling me there's a new tick in the area too, called the long tail Asian tick that consumes animals. It affects livestock. It doesn't vector to humans. It can just-
Yet.
Yeah, well, yeah, it's not known to be a vector yet,
Great.
Yes.
but it's coming.
George, one time I was going through all the commissions and all these things that are around us and thought we had a climate commission that had been appointed.
I don't think you really do. We looked at the list and there there are a heck of a lot of commissions, you're right.
I thought the city had one at one time.
I
Well,
think
They may have eliminated, who knows?
maybe that.
But this is countywide, this
Yeah,
isn't just
Yeah, it's also-
city. The city is, up to its eyeballs in commissions,
I think probably it was a city.
but the county
That I
is
was going
far
through. You're
less
right.
concerned.
You're
And,
right.
and that this is a public health issue,
It certainly is.
are you making a proposal for action on this?
Would you
Well-
like endorsement of the proposal from the health?
If the department or the board wanted to endorse it, that would be fine with us. But I just submitted as a matter of information for those who are interested to,
Yeah, why don't we have a chance to read this, find out a little bit
yeah,
about it.
take your time.
Yeah.
And when I think of how long it took them to come up with the board for the conventions,
Oh, gosh.
you know, the thought of jointly establishing a climate commission sounds,
There might be more enthusiasm for this.
maybe. But I mean, it makes so much sense. Because we certainly need to figure out what we're doing. And not only are summers getting hotter, but we're losing those cold winters that used to kill off
Yeah,
things.
ticks are year round now.
And the mosquitoes that are coming in, and everybody else that's,
Yep,
when are we gonna see the level of encephalitis going up from mosquito infestations?
well, it's not just the new diseases and their vectors, it's often things like the increased flooding in karst terrain,
Horrendous.
the extremes of rain events, and
And now that the state is allowing 25-degree grade for
slopes, yep,
For construction?
yes,
Yep.
the state just approved that.
Really?
except,
Hall.
except for the Lake Monroe watershed.
Yep, but
Which,
still-
we're,
But we have incredible slopes in this county.
yeah. Yeah, planning is going to be affected in many ways that we don't even think about now
Hmm.
by climate issues.
And our 100-year water events that happen monthly, weekly.
Exactly.
Hence some more of the big dig down on Kirkwood. How are they ever gonna solve it?
So I have, but, Nate, I have a couple of things. So did no one show up for the personnel committee meeting to get council approval or?
That
Or they-
I accept 100% responsibility for
Okay.
that. I had it on the wrong day. They
No
had,
worries.
they
It
had moved
it has
it.
traditionally been on a Tuesday.
Mhm.
Oh,
And-
they
and
moved
She
it.
had a Tuesday
Okay,
after
got it.
they moved it because of a holiday or
And it-
eclipse day or something.
It's been moved now, right? To
It's been
next Tuesday
Okay,
or something.
perfect, perfect.
Going in June, I will check my calendar
worries.
every day.
Okay,
Yeah, I got an email from Kim Shell
yeah.
that the council said, now she says you're up next, and I was like, "It's for what?"
Next for
It's like,
fun.
I felt
It's
horrible,
fine.
so
Stuff
I'm
happens.
so sorry.
Notice I didn't call you right away. I thought I'm gonna give you a date.
I wasn't being, I didn't know what happened.
Yes,
I
that's,
just got notice that, hey, no one showed up for the meeting, so we could get this stuff
Yeah.
fixed and changed, and I was like,
and it was,
she's
But Lisa,
worked on
thanks
it a
for bringing
lot.
that up.
Yeah, yeah.
it was at Crinchlick at a conference too, and so I was like,
And then at one point, will we revisit the Futures Clinic in terms of, that it's not, well,
Volume.
yeah, just sustainability. I mean, I'm concerned about that because we're spending a lot of money to employ people there and then there's no volume of patients there to be seen or whatever the issue is. So they're not sustaining themselves. And so,
Well, Steve and Lori and I had a chat with the clinic staff
mhm.
and they're fully willing to work harder than they were being allowed to work. It wasn't up to them. They're willing to do the work. They're actually seeing more patients now.
Mhm.
And I have no idea time frame to allocate to determine if it's enough or not. That's not a decision, but I know that they're seeing more patients.
Okay.
They're
So-
scheduling more patients.
Okay,
They're
good.
working on the schedule. They're interested in maintaining the clinic.
Taking care of.
There has, well,
So
I
there,
think there's been a little resistance because the staff is minimal right now down there. The clinic manager was making appointments and answering the phone, doing things like that. And so I understand what the resistance is to cross-training positions.
Mhm.
I mean, everyone, in every
Everybody.
organization, you have people that are gone for one reason or another, whether it's illness or whatever. And somebody else has to fill in and help do that job. Well, it's really advantageous if you've had training in that area already. But we're also meeting some resistance to cross-training down there. They say, wasn't my job before. Well, it was in your job description, however. Yeah, maybe we weren't asking, but if you look at your job description, yes, this is part of your job. So change is never easy. They haven't been
Right.
required to do these things in the past, so it's not like everything's just rosy down there, but, so it's still a work in progress. I think we made ourselves clear, and I thought we couldn't have, I don't know how I could have been nicer, but still get the point across, but I think the staff still felt a little put upon, by some of the things I asked them to do. And it wasn't that they're not doing a good job at what they're doing, but they just need to make it more efficient. It's time usage, basically. They're just used to having virtually all the time in the world to do something, and that's just not the way the world works.
Mhm.
I mean, I'm sure you wish you had more time.
Yeah, well, sure.
Yeah.
Right.
Example,
You mean
a new
they
patient intake.
Regularly on how many patients they're seeing.
I routinely go in and look. I spoke with one of them today and she said she believes that they did fit in 8 today. But I put a hard deadline on opening the schedule routinely on Fridays. So that will start the second Friday in June. Just trying to get some consistent patients that additional day. I think other than that, it's gonna be kind of streamlining those initial visits down to 90 minutes and kind of staggering and fitting in the shorter appointments in between the
As
longer
opposed to
ones.
3.5 to 4 hours to take intake for a patient.
That came up.
Yeah.
And it's, the electronic medical record system is very cumbersome.
And one would think that over time, with more use, one becomes more used to the system and, yeah.
What
But the
system?
patients aren't used to it.
Alice.
Oh, I use iSolus. It's
Oh,
pretty,
you do?
it's pretty, why is it cumbersome?
Well, I don't know what you're using compared to what they're using. They have different,
Yeah, they may have a different.
I think they probably got a
Yeah.
different platform, but
Mhm.
it takes a long time to do an intake.
Mhm.
It's not that the staff isn't conscientious, and I don't mean to imply that that they're not doing their job, it's just that they were just used to working at a certain pace, and that pace just isn't sustainable, so they just need to change some of the things that they're doing and become more efficient at it, but they're certainly, I don't mean to imply that they're not dedicated. I think the nurse practitioner is very,
Mhm.
conscientious and really wants to do a great job.
And in Steve's defense, he was very gracious about this.
Mhm. Mhm.
Tried to be.
Yeah, I thought you did a great job. I couldn't have done it.
But fear that anyone has kind of makes us push back. And I'm sure they're afraid of what they've never done before and are being asked to learn to do. And
Change.
sure,
Change, right?
So,
fear is a big one.
so the grant says that they have to bring in income of 8,000 to 9,000 per month. Is that, I read that somewhere.
That's
or
not the grant.
No.
That's really on average what we need
To
to
sustain it.
sustain overhead.
Sure.
Which
So it,
I don't think that's possible.
mhm.
So I think we're gonna have to plan on other revenue streams to help cover those gaps, which we have been currently doing over the past year, is
Mhm.
pulling from county funds to cover supplies and services, because it just can't, I mean, the costs are increasing and the grant is staying the same. Mhm.
And we really don't know what their capacity is.
Mhm.
We're still trying to discover that with the staffing that we currently have and the circumstances that we have.
Mhm.
Good
Thank you.
topics and good
Thank you.
questions. Thank you.
Oh, yeah. It's got our attention.
Anything else?
Lori, how did your visit go?
So with the state,
That's good.
I think it went
great.
well.
It was great. Was it helpful?
I think so. It seemed a little unsettling that they're not quite sure what's in the future. But I guess that's
But-
normal.
But I like the idea that, you know, they don't expect us to have all the answers because they don't have all the answers. And they're really looking for input from all of the counties and how can we get people who are doing it well. And that was the biggest thing that I heard that was helpful was, okay, so we need a way of being able to put this all out there when things are going well. And when we found a solution to one of our many problems with all of this, put it out there so other counties can share.
Mhm,
And so they're trying to do that through the 2 regional folks, but
mhm.
I think they need a much better platform for sharing than what they've got at this point.
And I attended one of the state meetings yesterday then, and that kind of came up, and what they're hoping is that people will build in, like we talked about the Parks and Rec contract, build in some of those requirements that the administrator or someone is going on site and conducting site visits to those organizations that you're partnering with, that you're getting photos and feedback, that you're getting those consistent reports. So then that can be shared online or with other organizations to be able to kind of show the impact and share success stories.
Some accountability.
Yeah.
That's a good thing.
And that is
Yes.
good. Not Terre Haute, Fort Wayne. So Fort Wayne is actually building Allen County and all of their service contracts. Essentially, they'll do a payment up front. Then they wait for their reports. They go do a site
That's excellent.
visit. If they haven't met
Mhm.
those requirements,
Yep.
then they don't receive the other portion of the
Yep.
funds.
That's
So that's something, a good point that was brought up to
Mhm.
consider.
That's like what you do with a hitman, I learned on the crime shows I watch. You pay him half up front and half after he's done the job. So I support that.
There you
I do that with contractors.
Yeah.
Well, I guess I just get the benefit of the doubt.
go. Well, thanks, everybody.
Thank you.
Great comment. Nice meeting.
And we
Yeah.
meet again
Thank you, Steve.
June.
Oh, yeah, what's the next date?
The third Thursday in June.
Third
Okay.
Thursday in June.
Whatever
Okay,
it is.
okay.
Thanks, everybody. I'll see you in person in June. Bye-bye.
By consensus, we are adjourned.